evening out there in Twitter land, Libre land, and YouTube land. I am your host, Dr. Nikki Johnson, and this is the second episode of the Free2Care, the podcast, where I will be bringing you some information that will help magnify your voice, the voice of doctors, the voice of patients who want to make healthcare prices transparent, lower the cost of healthcare, make your healthcare portable. You can take it anywhere you want, and make it affordable and accessible. We want to get this done, and the way I'm doing it, we're taking it to the streets. Tonight's topic is going to be part one of a series that not necessarily will be in sync, but it will be, we will be talking about the physician shortage, or really we're trying to get you access to doctors. And tonight I have two guests with me who are going to talk to us about one of the solutions for getting everyone doctors. So can I welcome, let's see, Dr. Henna Sawhney and Dr. Faarina Khan. Hello, hello.
Hello.
Yay. Hi, how are you guys?
We're great. How are you?
I am wonderful. All right. So you know what? We're going to do the first couple of minutes. I'm just going to let you two go for it. Introduce yourselves. Just tell us where you are, a teeny bit about yourself, and then how you discovered Free2Care. So who wants to go? Henna's at the top right of my screen. You go ahead and go first.
So my name is Henna Sawhney. I am a 2018 medical graduate from a British medical school, born and raised in California. But I actually heard from Free2Care from Faarina, so I think she can explain a little more about how she introduced Free2Care and the initiatives they've had, and how they align with our group's American Society of Physicians and the National Association of Associate and Assistant Physicians.
All right.
Yeah, but
yes. So Dr. Sawhney, yes, go back and tell, because we have an audience of people who are not necessarily in healthcare. We have a lot of people who are patients out there, and some are, and then we've got nurses. We have a pretty broad range in our audience. So tell them a little bit about your path through medical school and where you are right now.
All right. So I'm a graduate of St. George's University of London medical program. It was an international program, so I spent my first two preclinical years, which were primarily, lecture-based and a few rotations on the island of Cyprus, actually. So it was very interesting international experience. I was working with Canadian people, so a lot of my classmates were from all over the world, such as Canada, the US, UK, Asia, the Middle East, and all over Europe. So I spent the first 2 years there, and then my clinical rotations were in Chicago. I graduated in 2018.
And what does that mean when you say clinical rotation?
Clinical, right. So so depending on your medical school, there's core rotations that you have to do. So you're working with a specialty, say neurology or family medicine or internal medicine, and you, as a medical student, you're learning the skills of what it means to be a physician. So you're learning to take the history, come up with differential diagnoses, and then how you're going to manage that patient in terms of.
So you're really actually, during your clinical years, you're taking care of patients with a doctor supervising you, correct? Okay.
Right.
All right. And so you went through all of that. How many years did you do that? You did, that's 2 years. 4 years.
4 years. So 2 years, actually, so my program, it was 3 years of clinical rotations. So our first year was lecture-based. Our second year was clinical rotations in Cyprus. And then our third and fourth year, we had multiple locations. I happened to do them in Chicago. And so I have, 3 years of clinical experience where I was working under a physician, learning, how to take appropriate histories or focused histories and examinations, how to come up with these differential diagnoses, and learn how to manage, at the early stages of managing at least the basic like common diagnoses that you would have, like diabetes or hypertension or cardiac diseases, things that.
Well, and you learn that by actually seeing patients with those diseases,
yes,
though, correct?
Exactly.
Okay.
Yes.
Okay.
So it was for me, 3 years of, depending on the rotation, 10 to 12 hours a day, sometimes 6 days a week, working side by side with doctors and residents, and learning these skills and managing patients. So that was my medical education. I graduated in 2018, worked in clinical research for the past 3 years, and then now I'm working as an assistant physician in Missouri. So kind of going back into a clinical role, and here the difference between medical school.
All right, so I want to slow this down because I want to. What we really want to do is just talk about how you landed where you are now. So, so you are right now you're doing a research position. So most people, when they finish medical school, they go on to train in a specialty that they choose, and the way they have to train, they have to do an internship. And a residency, which can be anywhere from 3 years to 7 years, depending on the field that you pick, right?
Right.
So what made your path different?
I did not match for the past 3 cycles. So I applied mostly to family medicine, internal medicine, and pediatrics. I got an interview this past year and unfortunately did not match again in March. So really, there's no set path outside of residency after medical school. Okay. Anything else, it's either you're looking because you didn't get into residency, or you decided beforehand that there was another path you would pursue, and you kind of make up the trajectory and how you're going to go into that field. For me personally, the reason I went into research was because I did not match. And then it's been being in this limbo period every year, trying to amp up my resume, learn new skills, find a way to better myself so that I could be a better physician moving forward. And once I get into residency and hopefully become a board certified practicing physician. And there's a lot of people.
So let's stop there. Yep. Let's stop there, and we'll get to that stuff too. So, Faarina, you're next. I wanted you to introduce yourself to the group too. Tell us about, the name of your organization as well, and then just kind of do that little piece of where you are right now. And then we'll go a little bit more in depth into the process.
Sure, absolutely. So my name is Faarina Khan. I was born in New York and I grew up in Chicago. I ended up going to medical school in Pakistan. So that is a 5-year program, and similar to Henna, I had 2 years of your basic medical sciences where it's lecture-based learning, and then I had 3 years of clinical rotations, working under the supervision of a doctor and seeing patients, kind of, utilizing those important skills. And then after that, I stayed on for an additional year to do my internship in Pakistan. So that's basically getting, the way it was at my university was that you get 6 years of medical and 6 years of surgical experience. So I did that while preparing for my USMLE board exams that every medical school graduate that wants to practice in the US has to take. So I was done with my internship and most of my exams by 2016. And that was the first year that I tried applying for residency. Because it's not like, you graduate med school and you can just walk up to a hospital with your CV and be like, hey, hire me. Yeah. You have to go through the centralized matching process. So when I was unable to match that first time, I ended up working as a medical assistant for a year, Illinois, at like a multi-specialty clinic in the suburbs. And then I had some interviews that cycle, but didn't match again. So I worked as a research assistant for a year out in Wichita, Kansas, through the University of Kansas. And alongside that, I was pursuing my master's in public health, and I started my work as an assistant physician in the state of Missouri. So I ended up basically going through the process about 5 times, and luckily this cycle ended up being different. I did successfully match into a family medicine program in Oregon, and so I'll be getting started with that next month. But during the application process, applied for internal medicine and family medicine, pediatrics, and the combined medicine pediatrics. Very open and excited
Yes.
about primary care. But whatever was meant to be was meant to be. So as far as how Free2Care ties into this, we know David Bellet pretty well. He actually, I guess, found me through LinkedIn, and he actually reached out saying, that I see that you have this organization, I see that you're doing these things, and, I see that we can potentially align, because one of the tenets of Free2Care is trying to decrease the physician shortage that exists. So that's one thing that Free2Care and my organization, which is the National Association of Assistant and Associate Physicians, we align on that we're trying to decrease the physician shortage in different ways, because there's not just one solution for that.
Exactly. So, just I want to remind this audience, this show is about solutions. We want to solve these problems that are in healthcare. And one of those major problems is access to physicians. So you guys brought up a lot of kind of pieces to the puzzle, but to summarize it's a long journey to become a physician. So and not only just the college education, the medical school itself education, and then you also have to do that training afterwards. And each step of the way, you have to apply and get accepted, and you have to meet certain goals. So you two have gone on a much longer journey than other people have. And it's something you really feel passionate about, you get into and you keep going. You don't want to just change and do a different career. It's not what you feel like you were meant to do. It's not, but you have to work and you have to survive. So finding what we can do is discover ways that are going to help physicians become physicians in a less complicated fashion, but also solve some of the barriers to actually getting these doctors trained. So, but let's shift gears and let's talk about some of the reasons that we have this problem right now. And we're gonna, there's multiple problems that are contributing to the fact that there are not enough physicians for the number of patients out there. But we're going to hone in on the medical school and training portion of it. So talk to me, and I'll probably put up a little video, or some posters and pictures as you guys are talking, so that people can actually see. And if there's a specific one that you want me to show that from what you sent me, go ahead and let me know. So either one of you, just talk to me about why we're not getting enough doctors who graduated from medical school into training programs. What's happening?
Faarina, do you want me to take that, or do you want to take it?
You can go ahead.
Oh, I can. All right. So one of the main reasons is what we call the residency bottleneck. So to be able to practice as someone that has completed medical school and the USMLE exams needed to get a license, you have to get into a residency and then complete that residency and there's some states that have some other requirements that you can do, but that's like but the main thing is you finish a minimum of 3-year residency depending on the specialty you're in, and then you can be board certified. The problem is, based on the number of graduates or medical students in their 4th year that apply, there aren't enough spots to cover the number of graduates. There's I think the last numbers were about 10,000 every year for the past 3 or 4 years that have not gotten into residency. So, this is just accumulating every year, 10,000 graduates from, this is U.S. medical schools, so MD programs and DO programs, as well as U.S. citizens such as myself and Faarina, who go abroad and complete medical education abroad and come back, as well as physicians that have completed their medical school abroad and are not American citizens. Some have done rotations here, but they are non-citizens that are trying to get into a residency to practice in the U.S. So I think the number for this past cycle was 48,700 applicants within the match. So and it was a 78.5% match rate. So that means out of the 48,000 or so spots, only 78% were filled through the main match. So that means about 2 out of 10 people that applied did not get a residency position, meaning they cannot practice, especially if you are in the US. You can't get a license, so you cannot practice. For those that live in other countries or are able to practice in other countries, they can continue practicing in those countries if they're eligible. But if you can't get a spot in the US and you live in the US, you have to find another pathway or another career pathway or another field to learn some more skills, to boost your CV, and then hopefully try again the next year. There are some people get lucky as well where there's some spots that fill up over it, but that's very few and far between. But the main way to get a residency is through this match process. But there's not enough spots. And the reason is there's been a cap for the past 30 years on the number of spots to train these doctors. And this is because of funding that comes from Medicare. And so this is not like other jobs where once you've fulfilled the education requirements and the licensing requirements or anything where you can just go up to a hospital, like Faarina said, and apply. You have to go through this matching process where you send your application only at a certain time of the year. You wait for there's an interview season, and then after the interview season, you wait to see if you got a spot. And then there's a scramble period for 1 week where if there's any leftover spots and people that apply can try and get some last minute spots if they don't get it on what we call match day. This is also it's called the Supplemental Offers and Acceptance Program. So this week is actually probably the most stressful because you can only apply to a limited number of programs. And it's very quick. But the numbers are even worse because I believe for not this match, but the previous match, there were 12,000 applicants for 2,000 spots. So yeah, it's just a crazy process going through that. So every year we're actually losing out on 10,000 doctors entering the workforce, which is really unfortunate.
Oh, so weird. I'm trying to show this up here and I'm like screwing up. So that's not going to happen. It's all right. All righty. Okay, so we have this bottleneck that's happening. We don't have enough slots. We don't have enough funding from the federal government, which is where this comes from traditionally. We don't have another pathway to get funding for residency spots. And we're not in control of that pathway. So there's lots of barriers to even creating a private channel where we can fund our own trainees as they're going through this process. So it's not an option. We do depend on the government to actually train doctors. And that's where we are in America. So Faarina, tell me about legislative action at the federal level. What's present out there? What can we do? What can we get behind to help push this along?
Right, absolutely. So, the American Society of Physicians has been really strong in advocating for certain pieces of legislation. One of the main ones that we were really strongly advocating for was the Resident Physician Shortage Reduction Act. The original one of 2019 was meant to ideally create about 3,000 more spots every year for the next 5 years, and it would have resulted in 15,000 more spots. However, the legislation that sort of ended up making it through the process ended up looking like, they're approving like 200 spots for the next few years. So you're looking at, over that same period, instead of 15,000, you're looking at like 1,000. So, it's basically a drop in the bucket. Compared to what it is that we actually need. Besides that, obviously the pandemic has kind of turned a lot of things upside down.
Which you think would not even be, that would be the perfect time to actually start training more doctors when we need more doctors out there in the workforce, right?
Right. You would think that, but if you go back a year, when the pandemic started and you're seeing all the things on the news, they were looking at all sorts of other solutions. They were graduating medical and nursing students early. They were pulling retired healthcare professionals back into the field, and they were even calling, doctors with foreign training over from their home countries to come help out here. But for whatever reason, they weren't considering the workforce that's sitting right under their nose, that you call, if the hospital calls you and says, be here in the next hour, and help us out, people could be there in a heartbeat and be able to help. And, perhaps it could have potentially made a difference in the beginning when we were still trying to figure out what's going on. And there was so much, we were like, more patients were getting sick, more patients were getting hospitalized, and more patients were dying. And, we were still trying to scramble to find solutions at that point. But, eventually we did realize that, yes, we need better solutions to that. So, different places were trying to come up with different ideas. At the state levels, a lot of states were kind of opening up some opportunities. I know, like New York, especially New Jersey, was kind of at the forefront of that, trying to open up ways for people with training from other places could potentially be able to help out. But there were still limitations for that as well. Like, people got really excited and tried to apply for it. But again, like you mentioned, there were more barriers than, opportunities once you looked into it more. So people like Henna and myself were kind of sidelined when, we have the training, we have the education, we could help out. We want to help out. And, we were in that situation. So kind of getting back to the legislative purposes, that one piece of legislation was key. And related to the pandemic, there was one that was proposed regarding the COVID-19 Healthcare Workforce and Resilience Act, which was meant to try to mobilize people to be able to help out during the pandemic, but also to make sure to retain them, where they're working, or kind of thinking long term that, God forbid, if another pandemic were to come around, we should have people that know what they're doing, because they already learned it from the first time around. So, that legislation was still kind of starting to gain traction, didn't really get to the point where some of this other legislation has. And, we're trying to keep an eye out for other things. More at the state level, they're just trying to find ways to kind of deal with their own state shortages in different ways. And it's kind of where, Missouri sort of ties in.
Yep. So that's next step. So solution number 2 is what you guys have done, which is amazing. What you're doing, you're trying to survive, you're trying to live, you're trying to get the job, the career of your dreams going and get started. Because meanwhile, time is ticking, but you are active in actually making a solution a reality for a lot of medical school graduates. So, Henna, why don't you tell us about your organization? I'm going to have you both tell us about each of the organizations. What does each one have to offer? But Faarina, maybe do you want to talk just about Missouri? What happened in Missouri first, and then you guys could talk about the organization separately. How about we do that? Okay.
Totally. Okay, so back in like August of 2014, this legislation had been pushed by one of the Missouri House Representatives, Dr. Keith Frederick, who himself is an orthopedic surgeon by profession. He kind of realized that on one end, you have these unmatched medical graduates that have no other option other than to keep reapplying for residency every year. And on the other hand, especially with that particular state, there's a lot of healthcare shortages. If there's like 114 counties, I think 110 of them are considered medically underserved. So the whole state is in, dire need of more healthcare professionals. So he thought, why not, hit 2 birds with 1 stone and create this legislation that would allow these unmatched medical graduates to pursue licensure that would allow them to practice under the supervision of a fully licensed physician within specific primary care specialties in medically underserved areas. You have certain hours where you need to have direct supervision. Your first 120 hours are supervised. And after that point, you are then able to, quote unquote, independently see patients, with your collaborator being a set number of miles apart. Like they may not be in the building, but they're still, proximity wise, they're not that far away. But, with this licensure, what you're able to do is the same kind of stuff. If you were someone who matched into residency and you were kind of doing your outpatient rotation, all the same responsibilities and expectations would be there. You would be, taking the history, you would do the physical examinations, you would kind of discuss your differential diagnoses, the different things you feel like could be potentially wrong with the patient. You come up with a management plan with your collaborating physician that you're working under, and then you work with the patient to kind of share this management plan, make sure they're on board. So you address, their medications, if they need lab orders, any specialist referrals, any minor, in-house procedures that may need to be done, little things like that. You take care of all of those things because in a nutshell, you're basically going to be this patient's primary care provider.
Yeah.
You do all those things. So, yeah. And then you
on this show, we don't like to use the word provider.
Sorry.
we don't like to use that word. That word came from the insurance companies. They designed and devised that term to put us all in one category and to make us all into a commodity and so just to strip us of our identities. So we're not using that word. That is a banned word.
So, yes, my mistake.
That's all right. I'm teasing about the banned word, but yes, we prefer physician because that is what you are. You have graduated from medical school. You are a physician, right? So basically, you're doing the things that you will be doing during residency, but even at a higher level of expectation and commitment, because you don't have to go off to your clinic or your other clinic or but you are really taking care of patients and taking primary responsibility, and you're serving a need. We need primary care physicians in the country. That's where we're missing. We're missing a lot of the specialty physicians as well, but we really need primary care. That's where the huge gap is. So you are serving that need. Now, what is, so there, you are an assistant physician. We know that there are other allied health professionals that have been around for decades to basically help this role. We know those as the advanced practice nurse or nurse practitioner, or the physician assistant or PA. What's the difference between what an assistant physician does or how they've been trained and how a physician assistant or a nurse practitioner is trained? Henna.
I am still learning a little bit more about what it is, what the curriculum and the time commitments for physician assistant and nurse practitioners. But the main difference is assistant physicians or APs are people that have graduated from a medical school and have completed the exams or to be eligible for licensure. So it's the same requirements you would need to apply for residency. So if you take someone like July 1st is the first day of intern year for many people coming up, and one of them will be Faarina. If you put Faarina and me side by side, we have completed the same exams and the same minimum clinical requirements and educational requirements. The only thing is Faarina will be in a residency program, whereas I'm working as an assistant physician. However, this is not the same requirements for physician assistants or PAs or NPs. NPs, the education requirements are they work as an RN, and there's, I believe, to get the NP degree, a lot of them are online now, and there's other requirements, but they only have about 500, I think, required hours, whereas Faarina and I have completed, I think, about 6,000 just from medical school.
Oh, wow.
So if you don't take the stuff we have done after medical school, so since whatever Faarina has been doing, you know, working in the various things she's done, as well as an assistant physician since 2016, and what I've done since 2018, if you take us fresh on our graduation day, any medical graduate has completed a minimum of 6,000 clinical hours. You take that to a PA, that's a minimum, it's 2,000 hours. So we have up to 10 times that of a nurse practitioner in terms of training hours required to get our degree, and 3 times that of physician assistants. And we also have the medical degree. Like, we can go and say we are doctors because we have completed those requirements. I don't like to say that because I would wait until I get into a residency. I feel when I say doctor, I feel it's a board certified physician or someone that is so I like to say what we used to say in the UK, junior doctor, for anyone that's in training or has not completed the board certification process. But we have that degree and we have that experience. But the difference is a PA or an NP can, on graduation, after graduation completion of their license exams, get a license, but we cannot until we are in residency. And so that's what's so unique about being in Missouri, is this is the only state that has a program implemented where we can get that license. And it's been helping, as Faarina said, our very high need areas that are underserved and rural. And these are people moving from across the country, some from across the world, to live in Missouri and work here and provide that service to the community. And it's actually, it's been one of the most fulfilling experiences I've had after graduating from medical school, because you see how much your training actually prepares you for this. And how unfortunate it is that for 3 years I couldn't use this. And now I'm getting that chance, and I was honestly terrified, but now it's all coming back. So this image shows the minimum requirements. And then once you've completed residency, that can go 18,000 or above. So there's a stark difference in the clinical hours requirements between the 3 degrees. So
Okay, cool. All right. So, and you know what? We do know that just about 26, probably 27 states plus the Veterans Administration have allowed these allied professionals to actually start practicing without the supervision of a physician, or a collaboration agreement, or some varying levels of that. And that really has not solved our physician shortage problem anyway. And we'll talk about that problem in depth in a couple of weeks. But you know, that hasn't solved the problem. You really can't replace a physician with someone who's not a physician and who doesn't have that same training, like you guys just explained. So how do we then go about fixing the model that we have right now to train more doctors and get more doctors from medical school all the way through the whole process? So this is the part where I want you to tell me about your organization separately.
Okay. So I mean, we're technically both part of both organizations. But, I'll cover one, so cover the other.
Makes sense.
Yep. So one is the National Association of Assistant and Associate Physicians. And what that is basically, it takes your, Missouri licensed assistant physicians kind of as a starting point. And, as of, I think I checked yesterday, we have about 357 individuals that currently hold this licensure. So, we kind of kept in mind, and the hope is to continue to expand this similar model in other states. And we are starting to have varying levels of success with that. Most recently, within this past month, Arizona passed legislation The final version looks quite a bit different from Missouri's model, but essentially it does help mobilize unmatched medical graduates and get them to start training under supervision and be able to, work clinically at a level that's appropriate for them until they're able to get into residency. So, we're looking to improve the program that's in Missouri as far as increasing the number of opportunities, as far as, the pay scale and all those things, since it's, the legislation hasn't been around for very long. The licensure hasn't been along for too long. So we're still trying to, increase general awareness. Like, we're still getting confused with, PAs all the time. So the very first thing we have to do is explain that we're not a PA, we're an AP, and this is the difference. So there's that education component, the advocacy component. And like I said, the main thing is to just kind of make sure that other states understand that, this is a solution, and, we're willing to work with these other states to tailor something that will work for them. Like, I personally was involved in testifying for the Arizona legislation, sharing the benefits that the Missouri program had and how it's very crucial that, other states, consider this kind of legislation. Other states have this kind of legislation in the works, and we're trying to help support those states however we can and trying to get that legislation going. But really, it is trying to, in a nutshell, grow the assistant physician movement. The hope isn't that, APs are going to be around forever, because ultimately the long-term solution here is more residency spots so that everybody can get into residency and train properly. But until that problem is solved, we don't want people sitting on the sidelines that shouldn't be. Because, one of the other components that, people don't know about, or, it's not talked about as often, is that if you're looking at someone that's gone through 4 years of undergrad and a minimum of 4 years of medical school, some of us 5, some of us 6, it's not free. That costs money.
That is true.
Insane amount of student loans. I have colleagues that are $500,000 in debt. These are people that are married, have kids, working minimum wage, or unemployed. I don't even know how they're making ends meet and being able to, get by their day to day. So you have to give these people an outlet to be able to use their skills and, let them sustain a respectable living until the big problem, like you said earlier, which is out of our control, is solved. So this is a way for us to get into the workforce and get our dignity back, I think, on top of everything else.
Yeah, right. And it's, it's not even just your dignity, it's your confidence level, it's your, everything you feel about yourself, period. It's just your meaning, the part of your life is meaning and purposeful. That is just, that is rough. And to have to go through that for years. I mean, it sounds like, at least from the two of you having gone through that, what is the average length of time that it takes for a graduate who did not match, who has gone through as an assistant physician or hasn't, and then later matches before they decide to just not reapply?
Well, at this point, the program, started taking licenses in 2017. So we're only at like the, 4-year mark right now. So, I know people that, within their first or second year of working as an AP, they ended up matching. In my case, I almost hit my 3-year anniversary, before I matched. There's people that, despite, they've been working as long as me or longer than me and still haven't matched. Like, it's all over the board. Like, I know some people, like in my case, I'm 5 years, into it. I have colleagues that are like almost a decade out and, match the cycle. Like, it's really all over the board. There's no way of knowing, because there's so many different factors they look at. They look at your board scores, how many times you took them, how far you are from your year of graduation, where you went to medical school sometimes is taken into account. Like, you don't know what they're focusing on. And, you know, a lot of times they focus on things that you can't fix. I can't go back and change where I went to medical school. I can't go back and change when I graduated, you know, things like that. So what people in this position end up doing is looking for ways to reinvent themselves. So they have a new CV going to the next, you know, application cycle to make themselves seem clinically relevant to me. Like, hey, you know, I have something to offer. And, you know, try to, you know, basically sell themselves, you know, pitch themselves to this program, be like, I'm the best fit for your program. And, you know, you need me just as much as I need you, sort of thing. And kind of looking at the, you know, the flip side of it, like in my case, you know, I had 4 years of, you know, having these interviews with residency programs and then not matching. And like you were saying,
and that's expensive too.
Yeah. I did the math for myself. I don't know about Henna, but this process to get to this point now where I'm starting residency, I'm about 30K in the hole just from just the applications and then going for interviews and all the costs related to that. Like, I mean, that's just me. Imagine if there's like, and there's thousands, 10,000s of me's out there spending as much, sometimes more. Because I mean, and finances are also a constraint. Like I said earlier, we talked about loans and stuff. Some people can only afford to spend so much. So that's another thing. If you can't follow the basic recommendation of like applying to at least 100 to 150 programs per specialty that you're focusing on, I mean, already your chances are very slim because you're competing against, like, you know, Henna touched on earlier, so many people from within the states, people from outside the states, like, there's just so many different factors that you can't control, and you just have to do your best to, you know, tread water essentially.
Okay. All right. So what's next? I mean, what do we do? How do we help you guys?
Well, like I said,
help other students.
Yeah. So my organization focuses, you know, really specifically on the AP movement. You know, Henna and the role that we have with American Society of Physicians, you know, that's one component. Like, they definitely do support the AP thing, but, you know, kind of like Henna touched on earlier, there are some people who have hit that point where they're like, residency's not for me, or I've tried for way too long and this just isn't feasible for me anymore. I need to find a way to make money, pay back these loans, and move on with my life. So for the people that are interested in residency, we want to help them, you know, have an easier time going through that process, whether it's giving them guidance on how to go through it or linking them with clinical opportunities like the AP thing, or, you know, for the people who decided residency is not for them, helping them find different ways to advance their, you know, like their professional career, you know, whether it's research or, you know, pharmaceutical companies or healthcare consulting. Like, there's so many different options out there. So we just kind of, both organizations, again, we focus on educating and advocating and trying to find different solutions that work for the different people that we're trying to represent.
Well, okay. So right now your organizations are made up of who? Is it predominantly unmatched residents or unmatched doctors? Sorry.
Yes. So Faarina's, the NAAP is assistant physicians. So they tend to be unmatched medical graduates or people that have practiced as an AP and have gone on to residency. For American Society of Physicians, we started out as 10 unmatched medical graduates that actually, to this day, we have all not met in person. Everything's been done virtually. And so our target was getting more unmatched medical graduates and actually learning ourselves about what the problem was in not matching. Because as you touched on before, like, being a physician, it is a part of your identity and does determine your self-worth for many people. Not going matched, it can affect your mental health in so many ways, and you could feel like a failure. And thinking that this is an individual problem is actually one of the biggest things. This is not an individual problem. Those that go unmatched, it's not that they're not qualified or won't become great practicing physicians and help maybe like make amazing changes in healthcare. It's just the system is not allowing you to get into it. This is a systemic problem. And so that was our first
goal. Can we talk about that? Yeah, can we talk about that? We go. I know I'm interrupting you, but I just want to go a little bit in depth about that. What did that, because that question comes up a lot. And even from other doctors who are opposed to the assistant physician license, the question often comes up. Well, maybe these people aren't meant for medicine. Well, I mean, first off, to get into medical school is a rigorous process. Period. Whether you in American going to an American medical school or even to a foreign medical school. Some of the schools that are outside of the U.S. are a little bit more accepting. It depends on the school for sure. But once you're in, you still have to take the same exams and, and to complete and take all the licensing exams and all of that, that the American graduates do. So you're already a person who has a high IQ and a high ability to deal with stressful situations and process and reason and make logical conclusions and just be a scientist, and a person who can care for people. So I always have a hard time with that. But as a physician and a scientist, we have to look at this in more of a scientific way. So is there data out there that supports, a person who has graduated medical school? Should they get a spot in a residency program? Should they, or because they didn't get one, really reconsider a different livelihood? So tell me about that and how you answer that question.
So this is honestly a question that comes up all the time. This is not a new question.
Yep.
I would say if we go back to prior to the cap on the residency spots, if there are more spots than physicians and you are not matching, that's something I would say, okay, let's figure out, is this because you didn't apply to the right programs? Is this that seems like if there's a few hundred out of thousands, I would say, okay, maybe this isn't if it's less than 1% or less than 5%, I would say yes. Definitely you can think that maybe there's something on the application you need to work for and you can try again. But the fact that there's thousands, 20% or more going unmatched, and then there's this thing where, Faarina brings up, people matching 10 years later. I have a friend, actually one of our colleagues matched, and they have no difference from their application from last year to this year. And they don't know what was the difference that got them to match. They're their personal statement was similar. They just updated dates, but the exact same application was sent and they matched. So how could you say that this individual was better after a year with the same application, word for word? That's where I get
oh, wow. Yeah.
So it's wow, this can't be an individual.
That is a great example. Yeah.
Right. So I've had this question, going to a school that people aren't familiar with, they're like, how do I know your UK program is the same as an MD? I was like, well, the doctor that created the smallpox vaccine was at my medical school back in the day. But Henry Bence-Jones, who we know Bence-Jones proteins for multiple myeloma, was a physician at my university back in the day. I am in league with these people, which is astounding to even think about. But they don't know that. And they think, how do I know your education is the same as mine? And I was like, well, my school is older than the US is as a country. That should be enough to let you know that, yes, my education is probably up to standard, and being certified by ECFMG and completing the same exams as a medical graduate. I have completed the minimum qualifications, and I've gone through interviews and doctor said, oh, you get an interview, you'll match, you're fine. But I can't get past that step to get an interview because my board scores aren't through the roof. I'm not ashamed of that. I learned a lot about it. And I think I was also on the younger end of my class, so still learning about myself. But these were learning experiences. And as Faarina said, you can't change it. But everything I could change that was in my control, I have
the hardest part about that, and being on the end now, because I'm an attending physician in an academic center, and so I do interviews every year for both residency programs and fellowship programs, and the criteria that residency programs want a high success rate at passing board scores, and the reason why is because the ACGME, or that big umbrella organization that gives the accreditation, or gives basically the hospital the certificate, the license to actually have and run a residency program, requires a certain amount of passing rate for each specialty. Before they agree to continue that program. And so that is one of the many factors that leads us to select applicants, not on how we interrelate with them, what skills they have, what their letters of recommendation say, but mainly board scores.
Yeah,
it's insane. And, I fight this battle every few years. I was never a great exam taker either. And that is another thing that can completely just damage your psyche as well. You're a good doctor. You're a good clinician. If I sit and have a conversation with you, you know that I'm a good clinician, and you've seen me take care of patients, that. But I can't get past this certain number on this exam. And so it becomes this part of trying to get past the exam. But yeah, the exam is important. And, so that is one of the parts of the process that you're saying is one of the impediments to getting this done. So
no, absolutely. And just a comment on that, yes, board scores are definitely important. I think we all agree there is a minimum requirement, and it takes a lot to pass those exams. But I think the system just focuses so much on it right now that a lot of people that may not make that minimum cut on a score that's arbitrarily set at most universities. It's not actually that if you get a 260, you can only become an orthopedic surgeon. There's no data on that or anything. It's kind of, with the times, this has been accepted as the norm. The higher the scores, the better chance you get of matching, the better chance of you getting into a more competitive specialty. But in reality, it's only one part of being a physician, taking that exam. And I would say passing the exam is less important than being able to apply that within a clinical setting, to be able to build those relationships with patients. And you might have a great score. And I can say this, I have some colleagues that are geniuses that can take a test without needing to study, retain information. But when it comes to the need of communicating with the patient and getting that same information out from a human being, they actually aren't as successful. And a patient is not an exam.
Absolutely.
When you seeing actually,
it's not a piece of, it's not, the patient's not a book.
Yeah, there's a lot more.
And an exam question, right?
Yeah, I mean, Henna's being a lot nicer about it. I'd be a little more blunt and say some of these people have the bedside manner of a doorknob.
Yes.
Just 270s doesn't mean you know how to interact with the patient. So,
these are human beings you're dealing with. Yeah.
Yes, exactly.
Right.
These aren't textbooks and these aren't papers. So kind of tying into both your guys' points, there's been so many studies that have been done, over the past few years and more recently that prove that having higher scores or lower scores does not actually correlate to what kind of clinician you'll be. If you scored well on step one, doesn't mean you'll be a great clinician. Just because you didn't score so well on step one, or you passed it on a second or third attempt, it doesn't mean that you'll be a not so stellar physician.
Correct.
The easiest way to look at it is Henna in her urgent care clinic, or me when I was in my primary care clinic. I can't name a single patient that ever asked me, "Hey, what was your board score?"
Or even you took a board exam. That was
mine was P. Mine was P for pass.
Exactly. The patient's never going to ask. The patient's never going to care. The patient cares about how do you make them feel? Did you take care of them? Did you address their needs? Do they want to come back?
Yes.
Do they feel
I will have to say, I graduated medical school in 2001. So I guess it's now 20 years. In 20 years, I actually have had one parent ask me what my board scores were.
Wow.
One.
They have a medical background?
She was quite interesting. She was an educator, and when she asked me, I said, I don't remember. Honestly, I don't. I passed them. I have my certificates. I can show you those, but I don't remember. There are people who know I was in the top 5th percentile or whatever. Right. I don't care. I passed it. I'm working. I'm taking care of your child very well. Yeah. So yes. I mean, so that's kind of like the meat of it, and that's the practical answers and things that we see. But we can't change that because that's the thing that we're not behind that force. And at one point on this show, we will talk about how all of these entities are connected with one another. So the ACE, all of the places that train physicians, the hospitals, their insurers, the pharmaceutical companies, the pharmaceutical benefit managers, all of these people are working together, the American Medical Association, to maintain this status quo. And they are putting, bluntly, they are putting profits over patients. So we are using these kinds of numbers and depriving people of people who would be excellent physicians for them. So depriving them of this access to care, and then trying to fill it with people who are not physicians, who aren't trained and who aren't qualified, and putting people at risk. And so this is one of those things that really is infuriating to me. It's one of the most passionate areas for me, is to help us improve that. So we have talked about increasing funding for residency training, which means you're going to increase more residency programs. There are still some barriers. It's not a simple solution there, but that is one that can be easily done, is get the bills that are already written. And there's more than just the one that was in 2019. There's also a rural track one. And just in the last 5 years, there's probably been about 4 or 5 of them. And most of them just never left committee. So what I want to tell the audience is, or people who are watching this, call your congressman and tell them that in order to get more access to physicians, you need to train more physicians. We have them. The medical schools have churned them out. They have responded and done what they needed to do. But we are increasing our national debt by sending bright young professionals who would be wonderful in any setting to medical school, only to turn them out and not allow them to be able to train and then become a physician. So tell your congressman, call their office and say, please, more GME funding. More GME funding. I am not a person who likes for the government to solve everything, but this is how the government has decided it wants to fund training for physicians. Right now, we don't have an option for a private source of this. I would love for innovation to be able to take over and for us to be able to privately source this. But this is what we have right now. And we are in a crisis of numbers for physicians and nurses. We need them. So we need some funding. We're spending money on God knows whatever else right now, billions and billions of dollars in packages that aren't going to directly benefit Americans. This is one that can. And I'm sitting here with 2 people who are American citizens, trained in medical schools, who have had a hard time getting a spot to practice and train in residency. That's absurd. So that's number 1. And then number 2, each state, call your state legislators and tell them you want an assistant physician license. If it's not there, you want it. You want to keep it. so that you can have access in rural areas, all of the underserved areas, to someone who's trained in medicine, how to diagnose, how to treat, how to have that kind of responsibility, even though they're supervised by another physician. You want that. Those are the two options. And then the other thing is what we didn't talk about is how can the public support the two of you? Is there any information on your website, Henna, where people can kind of donate and help out? I don't know, Faarina, your website is still getting built, but any way that we can donate and help support?
Yes, definitely. You can visit asphysicians.org. If you'd like to join as a member, you don't need to be a medical student or a physician or a resident to join. We take any help, honestly, because what we're looking for is we know this is a problem, but we don't have, and we're all very talented, but the more support we can get and the more talents that people would like to provide or donate, however, to help us would really help our nation's like public health crisis that we have right now. Like you touched on it, we don't, one of the things that we tried to educate with American Society of Physicians was that we don't actually have a physician shortage. We have a training shortage. There are plenty of doctors there that would be willing and able to help at the moment, but they're unable to get the training spots in order to get the license necessary to practice. So we have a training shortage and we need to train more doctors. That's really what we need. And this is not at the medical school level. This is at the residency level, the actual trainee level of getting to board certification to be able to practice. You can also email us if you have questions on how to support or volunteer with our group. We have several committees working on public relations and advocacy and some event planning and education of the public. And really, I think just the more people understand what it means to get to the end of medical school, to go through training and the obstacles that this is something that's hurting all of us. We have young people that aren't able to, fix their debt and contribute to society because they're unable to get jobs at their level. And then we have patients that don't have access to doctors and quality care. It's not just access, it's also access to the type of care. So this affects not just, us as physicians or in the medical system, the patients and the broader public. So we, if you'd like to donate, if you'd like to help us with our PR or call, and we also have resources on who to call to find out who your legislators are and how to reach out to them, like template emails and phone scripts, things we've been doing over the past year, hoping to get this legislation passed. But I think the louder we are as one voice, the more effect we'll have, especially since this is a federal issue. This is not just state level problems. And so it's a national issue. And just seeing what happened with the pandemic,
it's a national issue, but we can tackle this at the state level. Exactly. That's the great thing. We live in a republic. So this is one of those things. I get excited when there's things that we can actually do at the state or local level, because those are the things that directly impact us as Americans. If we're waiting for the federal government to actually pass a bill, number one, when they have like 10,000 other things that they think are more important, they pass the bill, then that funding still needs to go to your state, to each state, and then your state government has to decide how to allocate that. And so it's not the best way to go about it. So if we have a state by state solution, that's what we need to go for.
Yeah. And the other point to keep in mind, one, this is the component of the general public, but kind of touching on, NPs and their varied success, PAs and their varied success. What is their magic formula? It's unity. There's so much unity within their groups with lobbying efforts and reaching out, but that same level of unity does not exist within physicians. You know, we have the doctors that I've met in Free2Care, such as yourself, that have been super amazing to work with over the past year that I've known you guys. We need more established, fully licensed physicians like you to support, you know, doctors who want to train like us. You know, like you're talking about, you know, pushing states to, you know, do this AP legislation. But a lot of the times our biggest opposition comes from those states' medical societies because they don't understand what we're trying to do. There's this misperception that we're trying to bypass residency when that is not the case.
That is not true. And Free2Care is also not advocating that. We want these doctors to get into residency training positions.
To get into the system,
take boards, get certified, initially board certified, and be out there and, you know, and do it, and then train more doctors after that. So
we're trying to eradicate the word unmatched. That's what our goal is.
Exactly.
But unfortunately, it's not going to happen overnight. So you need something, at least something to start off with, to allow us to keep our clinical skills and then provide this care in those areas that need it until we can get into residency. And hopefully it won't take like for 5 or 10 years for people to get into residency. They're working, more solutions will come out to increase residency spots, and more people will be able to get into the system and get into residency, so that there will be a day where the AP license will actually not be necessary, because when you graduate from medical school, if you are qualified, you'll get into residency and you'll be able to fulfill your career path.
All right. Well, I like ending on a positive note. I really enjoyed having the two of you. We've chatted by text and by email and in a little bit of a phone call, but I have enjoyed getting to see your faces, getting to see your spirits and your energy and your passion about this topic. And Free2Care definitely supports you. The point of this show is to get everybody in the public out there aware of the problems and how they can help and support and advocate for themselves to get the medical care that they need. So thank you all who are out there who viewed today, who commented. Please like the channel, subscribe. Subscriptions, drive us up, boost us up in the food chain on YouTube. And LibreTV.co is also a fantastic place to subscribe. It is a channel where we won't be censored either, so we can say what things that we want to say without having the risk of YouTube taking us down. And so we have to support each other in getting this message out to the public. So like, subscribe, and share this information that you learned. So help us grow. Help us grow and get the message out to everybody. So thank you. We went over almost about 10 minutes. But we had a lot to cover. And I'll get better at the time as we go on. But thank you guys again for coming, and have a wonderful Memorial Day weekend, commemorating those of us those people that we know and loved, or just people we didn't know and we appreciate, who died in service for this country. Bye-bye.